Yes. I received some speaker honoraria from Boston to give presentations like this. So the next slide, please. So I just start with a typical case we are treating here in Zurich. So we have a 55-year-old woman. She complained about 3-day history of shortness of breath. Also in her personal history, there's breast cancer treated with tamoxifen. On initial presentation, she looked like quite hemodynamically stable with a normal blood pressure. She was tachycardic with a heart rate of 103. Her O2 set on rumor was 88%. Troponin test was highly positive. And as you can see on the CT scan, she had not only a dilated right atrium, but also a dilated right ventricle with an RV-LV ratio of 1.4. And you can see a saddle embolus on the upper image with a complete occlusion of the right pulmonary artery and a partial occlusion of the left pulmonary artery. Next slide, please. This is just the still frames of the angiograms. On the left panel, you see an obstructive thrombus in the right pulmonary artery, and you see a partial occluding thrombus in the lower lobe pulmonary artery on the left side. Next slide. And then what we do is we are placing ECOS catheters. It always looks the same. We are using 12 centimeter treatment zone devices over soft glide wire. And introduce those catheters, and we are working with a fixed dose regimen in Zurich of 20 milligrams TPA over 15 hours, accompanied by full dose heparin. So we're not reducing the heparin dosage, and we are targeting an anti-10A level of 0.5 to 0.7 during catheter-directed thrombolysis with ECOS. Next slide, please. So I don't want to waste time talking about the ESC guidelines, but just to remember, we have the 3 risk groups: high risk, intermediate risk, low risk. High risk clearly is red box, means emergent reperfusion treatment required, as well as hemodynamic support like pressors, and also sometimes ECMO placement. Then we have the dark orange patients that should be monitored on an at least intermediate or intensive care unit, and you may consider reperfusion therapy in these patients if they really are sick or on the border, or if they clinically deteriorate over the next couple of hours after presentation. Next slide. So this is just our Zurich pathway for non-massive, or let's say non-high-risk PEs, that patients that have no clinical signs of shock, have a normal blood pressure. We use a PESI score to differentiate between low-risk and intermediate-risk patients. If the PESI score is increased 1 or more points, we routinely obtain the troponin test, and we measure the RV-LV ratio on the CT scan. And next slide, please. Then we go to page 2. So we have the intermediate risk patients where we then get our PERT team activated, and the PERT team will then decide or suggest what to do with such a patient. If it's an intermediate low-risk patient, so meaning that either troponin test is negative or there's no clear RV dilatation, we usually do no revascularization therapy at the beginning, send the patient to the regular ward. In some patients, we may consider doing ECOS if there's a low risk of bleeding and patients are highly symptomatic. In the intermediate high-risk group, typically, so where both the echo is positive and the troponin test is positive, we perform in most cases where the bleeding risk is not increased an ECOS treatment. In some patients, we may also consider no revascularization at the beginning. All those patients go at least to the intermediate care unit for the first 24 hours. Next slide. So this is our flow chart and SOP for the high-risk group. Here, the PERT team is activated much earlier already when there's a suspicion of high-risk PE. So patient presents with a low blood pressure or has undergone cardiopulmonary resuscitation. The PERT team is activated. Usually the bedside echocardiogram is performed immediately. We have an echo machine in the shock room, and this is done very quickly. Then patient usually goes to the CT scan, and then the PERT team will really be in the shock room from the very beginning, and questions that will be asked to the PERT team is, do we need an ECMO prior to reperfusion? Do we go for systemic or catheter-directed thrombolysis, or maybe the bleeding risk is high? For example, a patient had a syncope and had a trauma to his head, then we may not consider thrombolysis but go for a flow retriever thrombectomy in our hybrid room with surgical backup. Next slide. So this is just the ECOS device in an in vitro experiment with human thrombi. You can see the bursts of the ultrasound energy being delivered over the device. Next slide. We also performed an in vitro study where we tried to quantify the effect of the ultrasound inside the ECOS device. And what we measured in an overflow in vitro model of human clots is the D-dimer increase in the overflow fluid during thrombolysis. And we also measured the reduction in clot weight. What you can see is when you compare the last two lines of CDT where the ultrasound was switched off versus the USAT where the ultrasound was switched on, that we clearly had much higher D-dimer levels in the USAT group, and we also had a more significant reduction in clot weight during ultrasound-assisted thrombolysis. Next slide, please. This is the evidence from 2013 to 2017. It's an old meta-analysis showing that 1,007 patients were treated in various studies over the years. Of note, 20% of those patients had high-risk PE, so 180 patients is quite a lot. The mean or average TPA dose that was given during thrombolysis was 25 milligrams. In-hospital mortality was quite low, with 2.2%, and the bleeding was also quite acceptable. Major bleeding was 2.7%.